I'd like to start with a couple questions that are just going to run down the panel.
Can I
Oh.
maybe make a,
Sure.
I won't go be as provocative as rebuttal, but just an observation about, I mean, I think, and again, it's one of those things that happens all the time, and then we seem surprised when it happens, or the state takes a specific action to accomplish a specific goal, and then when they accomplish that goal, they somehow seem surprised. And I think, I think MLTC enrollment is exactly that. I mean, for better, for worse. And again, in talking about, we create new benefits, and then people take up those benefits. Providers who offer those benefits stand to gain revenue from offering those benefits. I mean, money is an incentive, is basically where I'm going. And if you if you offer money, then that drives behavior, And so I think the MLTC, when there was an incentive, there was a large payment for MLTC to enroll people in MLTC, plans made that happen, and that drove up enrollment. And I won't go into some of the scandals that occurred with that, but a little too, still have the scars, but there was a big enrollment with MLTC, and I think similarly with consumer-directed, people were like, "This is a great program. It's so much more cost-effective, and so let's all use that program." And then the program grew, and then people were shocked, And I think in the primary care world, we've experienced the same thing with PCMH incentive payments, the patient-centered medical home incentive payments. The state said everybody should be a PCMH certified medical home. Everybody should be getting comprehensive medical care. We're going to put out these payments to providers to become PCMH certified, and everybody's like, great, they took that up, and everybody got certified, and now they're saying, oh my God, I can't believe how much we're spending on PCMH. Yeah. It's out of control. So I just
Right.
Right. So I think in Harold's terms, it's unintended consequences. In other places in my life, we've called it "be careful what you wish for." I think it's just that's a fact of the money.
So maybe I'll change gears a little bit to respond, to follow up on what you just said. When I first started hearing about the concept of home-based care, it probably wasn't, even back then, it was the 1990s, it probably wasn't that new of a concept. But when I heard about it, the idea was that this was less expensive than putting someone in a nursing home, and it was also vastly preferable to the recipient of the care. They got to stay at home instead of being in an institution. And so it was a win-win, save money, better care. My suspicion as I've followed this issue, like for example, I've looked at our nursing home population. As the home-based care has gone up, the nursing home population has stayed high. There hasn't been an offset. And so I'm wondering what folks, whoever cares to talk about this, what you think about that. Are we, in the end, is it about saving money, or in the end, are we expanding the population of people who are in Medicaid and receiving really costly services? That's my question. Like, is there kind of a woodwork effect?
Well, I think that's part of it. So the woodwork effect theoretically is that there are people who were somehow getting by with family supports, with other ways in which they were able to get through the day, who were unaware perhaps that there was a program that they potentially could qualify for. We do have one of the easiest ways to qualify for Medicaid is when you're looking for community-based long-term care. There is a much shorter look-back period. You're not having quite as complicated a transfer of assets challenge and that sort of thing. So it's relatively easy to do. I don't think it's, there could be, I think there probably is some fraud in all of the programs that we're talking about, including that program. I don't think it's exceptionally present there, but there is probably a dynamic which says if government's going to pay for this, and I can then go about my life and not be the caregiver to my loved one, or as the consumer-directed program provided, I can actually be paid to be the caregiver to the person I love. It's not surprising that people avail themselves of that, particularly when there were programs advertising themselves on the subways of New York City as being a great way you can get paid to take care of your family member. So I think that is part of it. There are some subset of individuals in the program who are actually more expensive to be cared for at home than they would be in an institutional setting. But we have very strong principles that say people should be cared for in the least restrictive environment possible. And while from a pure dollar and cents perspective, it might be less expensive to put individuals in a facility of some sort, that's not an option that we're prepared, I think, to enforce. I guess there was one other element of this that I wanted to mention that I may. Well, there is the sort of, as they say, the pig in the python problem of this population of older people who are also driving this up. And I think here's the other point. The managed long-term care program was premised on the notion that it would provide a level of coordination and to some extent some utilization review and some discipline in making sure that people got all the care they wanted, but only the care that they needed. And the problem has been that, as the managed long-term care plans will tell us, when they're trying to make those tough utilization decisions and determine that someone actually doesn't need quite as many hours of personal care as they're currently getting, or doesn't need the increase that they have requested, there is a fair hearing process that almost inevitably rules in favor of the patient. You can understand that. You're an administrative law judge. You have a family and a beneficiary in front of you who says they need more services. You have an evil plan on the other table that says, no, I think we have to contain this to some extent. Our assessment is that this person can get by with fewer hours of care. Almost inevitably, not only does the ALJ rule in favor of the patient, but in some cases provides more hours of care than the patient or the beneficiary has actually asked for. And that is a problem that we've proposed some solutions to that are still pending to try to strengthen the regulations that provide the plans with an ability to actually make those tough decisions. That's what they were put in place to do, and if they were permitted to make those tough decisions, I think we'd see the growth in hours diminish.
Next, I'd like to ask a question for Laura. During my talk, I mentioned that per recipient spending came down pretty sharply, and I intimated that I didn't think that this had caused major problems on the recipient end. But I have to admit that that's very difficult to measure. Outcomes or, there's some effort by the state to measure outcomes. I don't know that I trust the results that they're getting. But I mean, there were sort of these big national groups would look at our Medicaid system and they would say, it seems to be improving at a time when the per recipient spending was going down. I'm wondering from your group's point of view, what was the experience of that roller coaster when per recipient spending was coming down and then was it going back up? Did that have a corresponding effect on benefits, on the quality of care, on the ability of people to get services?
It's a great question, and I'm going to actually respond to the home care issue first. A couple of things, and as Jim said, it's as far as providing services in the most integrated way, as Jim put it, it's our principled approach to provide services in the most integrated setting. I would also add it's the state's obligation to do that. And in addition, Bill, you mentioned that in referencing personal care, it is by statute an optional service, and that's true. But I would caution that looking at services or benefits as to whether they are optional or not is quite dangerous. Because this state has made some principled decisions, as Jim said, to provide certain services, including ones that the federal government considers optional. And when you look at the list of things that the list of benefits that are called optional, it includes things like prescriptions and glasses and things that, if you need them, they're really not optional. So I'll just add those points. And as it relates to the last few years and what we've seen, I would say that some of the initiatives that came out of the MRT, the benefits changes or the managed care changes, some have been relatively okay. In other words, there has not been a significant impact on access to services or care. But we have seen where there were instances where many decisions were made and initiatives were put forth to change the numbers. We have seen, as one example, I've thought about. There was a benefit change to limit, or I think it was actually to take away the footwear, orthopedic footwear benefit. And this as one example, there was a case, I think it was in Rochester.
Yeah.
And ultimately, the benefit was restored. So as these initiatives have rolled out that were all intended to change the numbers and bring spending down, there have been instances where there have been negative impacts on people, whether it's as intricate as access to orthopedic footwear, or as global, so to speak, as access to services under managed care that has not always gone smoothly.
So, Bill, can I take a whack
Sure.
at that too? So, putting aside, obviously, examples like the footwear, and which I'm familiar with, but if you look systemically, I think there's an important observation, which is New York is, if not the most advanced, one of the most advanced in measuring quality, access, and consumer satisfaction. This is hard to do in healthcare, as we know, but the health department has done a good job. They invest a lot of money in it, and they work at it. And what we see systemically, first, we're measuring it. Let's just pat ourselves collectively on the back, because in the old days, we didn't measure anything, okay, under fee-for-service. We had no clue what patient outcomes were, whether services were being delivered, and whether there was consumer satisfaction. So if you look along the trajectory, the state's come a long way. And what we see systemically in the quality data is that the quality is improving. I mean, by all the different metrics, which again are imperfect, but the whole science is imperfect, quality outcomes are up and consumer satisfaction is up. That doesn't mean that there aren't instances where somebody's unhappy about something, because this is healthcare, but measured across billions and billions of dollars of spending, what you see is a good story in New York for quality and for consumer satisfaction.
So, I mean, that sort of feeds into the question I was going to ask you, Harold, which is, which kind of boils down to, what does managed care bring to the table? One of the big trends under the Medicaid redesign team was pushing more and more people into managed care, including not just mainstream populations, but also people with severe disabilities and who had traditionally been treated through fee-for-service. Is it primarily about quality, or is it about utilization? Is it about cost of service? When I saw those first 5 years of numbers, I thought, wow, managed care is having a dramatic effect. But then managed care is still there, and the numbers started going up again. So what has been the effect of this switch to managed care?
So I think the main benefit is accountability. Again, in fee-for-service, there was virtually no accountability of any kind. Here you've got organizations who take on important legal and financial and policy obligations and are held accountable with strict sanctions when they don't meet it. And what goes into accountability? It's quality, it's consumer satisfaction, it's value. Value is typically defined as cost plus quality. And we can measure it, which we never could before. There is an important financial component, but I often say it's not It's not about cutting costs to actual decreases from year to year, nor is the cap. But it is the same principle of predictability that is critical to the state for the budgeting process, because when you hand risk over from the state to managed care organizations, they have to live with that. And some years there's red ink, but plans don't come back and say, oh, we lost money, this is cost-based, pay us more. They're expected to suck it up, and they do. And of course, that's why we have reserve requirements for health plans. So, but again, to me, all of this rolls up into the concept of having entities who are accountable for both care and consumer satisfaction and quality outcomes. And of course, bringing to the table very important resources to do things, especially in information technology and measurement of outcomes and managing things that the state cannot do and did not do.
Can I just add a quick comment to that? Harold put it very well. We used to have a Medicaid program that gave someone a card that said, this is great. You've got this long list of benefits. There's virtually nothing in the healthcare world you can't get. And you don't have to deal with a managed care plan. Just go forth and get service. The reality was when they went just about anywhere, they were told, I'm sorry, we don't accept Medicaid recipients because the payments were too low. So you had, that's a bit of an overstatement in terms of what the world looked like before we moved in this direction, but not completely. And the reality now is there is access to services. A broad array of providers participate, including primary care. And it is not surprising that it's been, I think, a success, both in terms of quality and consumer satisfaction. Now, the challenges I would acknowledge with moving populations who have more serious disabilities into the program is that, from my own personal experience, managed care works great because, if my family is being denied a service, I raise hell and figure out a way in which someone's going to change their mind. And you need to have strong advocacy to make sure that the plan does the right thing. I think that's just kind of inevitable. It's worked well in my life. It works well for many people. But one worries about people with serious disabilities. Who's going to be advocating for them to make sure that they continue to get the services that they need? And I think that's going to be a challenge. We need to build into the system a capability for people to advocate. And that's why Laura has been put on this earth. But
So I'm going to ask a question and go down the panel. And it's basically, should the global cap stay the way it is? Should it be changed in some way, and if so, how? Or should it just be abandoned and put in the circular file?
want to go?
What? No. I mean, look, I would keep it, but that doesn't mean keep it and frozen in time. I mean, I would say keep it, but add some, I'll say, budgeting integrity to the process, okay? That means if you're going to have superpowers, and we may see superpowers be invoked this year, then some of the things that you identified, again, moving things into the cap and out of the cap, and this is carved out, and minimum wage is added, and it's supposed to be outside the cap, but some of it's inside the cap, that doesn't work well with superpowers. I mean, as you say, the sort of deal was we would have predictability, we would have steady increases, but there was an enforcement mechanism, and the trade-off for getting the predictability and the sort of steady increases was, but there is a stick to enforce it. But the people's willingness to accept the stick is dependent on everybody trusting and understanding what's going on. So when you suspend monthly reports and you do all these other things, I think it reduces the confidence people have in what the cap was supposed to do in the first place.
I would add, I also think the cap is a good idea. I think it's not a mistake necessarily to continue to have it. And I agree with what Harold said. And I think the way to characterize it in some ways is to call for transparency and being able to have a a look at what's in, what's out, what the loopholes are, or special programs, and being able to have a clearer picture of where money comes from and where it goes in a very transparent way.
I agree. I think it's a good discipline to have, hopefully, a very transparent way to kind of keep track of how we're doing. To me, it's very reminiscent of the conversation that we were having a couple of years ago with the repeal and replace suggestions about block grants and per capita caps that were part of some of the alternative proposals, which I will confess in progressive circles that I hang out in, made me somewhat unpopular to say that I can see the wisdom of having some sort of discipline like that, even at the federal level. If obviously the devils are in the details, so the numbers are right, if there is some inflation factor connected to it. So I think that level of discipline is just essential. We have to recognize we really have to contain healthcare costs. We have to have some discipline to do it. But as long as it's a cap that is subject to redefinition and manipulation, it's not particularly productive. And I think it is not a substitute for really tough policy decisions that are actually going to do something about those expenditures and not just keep track of them.
Yeah, I think I would agree. I think, the question is, what does that mean, maintaining the cap? I mean, I think we've seen that that's, not a fixed kind of calculation. So I think there's kind of a question of what would be in and what would be out, and is that really something that's maintained? And I think the other question would be, what are the priorities under the cap? I think that a lot of the spending that, when you do a per recipient calculation, you kind of divide the number of enrollees by the total spend. But as has been noted, a lot of the spend isn't necessarily on beneficiaries, on recipients. It's on kinds of subsidies and other kinds of provider-focused payments, rather than providing care and investing in the services that are going to enhance the health of the population.
Okay, so my next question is, maybe we'll go the other way this time. We now have a situation where we have, I guess the CBC has estimated it's $3 billion plus deficiency in our financial plan around Medicaid. So, that it's in the total state budget too, but. And, there's a constitutional obligation to keep the budget balanced, and the governor is sort of rattling his saber a little bit about, what we have to do something about this. He's also raised the possibility of postponing more payments. Do you guys have any suggestions for the Cuomo administration as to how they should handle this in the short term? The next, 6 months.
Yeah, you go first, Rose.
You go first, Rose.
Or things that they should not do.
Well, I mean, I think that Medicaid spending isn't a bad thing. I mean, Medicaid spending brings in a huge amount of federal revenue to this state. And I think that, even in other states, this was the carrot with the ACA, and that, I've always been flabbergasted that other states did not take up the opportunity to bring in more federal dollars. I mean, in New York State, Medicaid is a verb. We all know that. It's something we do to create revenue, and that's creates a lot of opportunity. That brings in a lot of money. And if we want to, New York has also been very creative, I think, always traditionally in looking at where can we bring in, what are the services that have a higher match. I mean, that's why we have health homes. I mean, it's not that all of a sudden somebody realized care management was a great idea. It was that there was a 90% federal match for health homes. All of a sudden, everybody's in a health home. If we had a 90% match for housing, everybody would be housed. So, I mean, I think that, to get back to that.
Isn't that actually what explains the numbers in your slides? Excuse me. We spend so much on healthcare as opposed to other services because of that desire to draw down the federal aid.
Yes.
Okay.
So let me.
How about solutions from Jim?
We have been in conversation with the governor's office and have suggested, I counted, I think that we have like 31 thoughts that are various, some of them politically infeasible, others probably dramatic and drastic.
Tort reform one?
Well, there is, and I would say this. So the only one I'll mention, because I feel like we just gave this to folks and would be inappropriate to start talking about it, but one I take personal responsibility for. When I was, again, back in the ancient era of the first Cuomo administration, we had a malpractice crisis. We did a lot of things. Some of it worked pretty well to try to contain it in the short term, to come up with periodic payments of large awards, some other important limitations on contingency fees. But what we also did is came up with a program that buys excess medical malpractice insurance for physicians across the state. $127 million is spent on that program now. It's not my favorite achievement from my time in government. I don't think spending $127 million on buying malpractice coverage for physicians at this juncture is a good use of our funds. It's not Medicaid, it's HCRA dollars, but most of HCRA ends up going to Medicaid, so it essentially is a part of our healthcare spending. I think if we did do that, it would be appropriate, and I'm sure the Medical Society would be quick to suggest that there are some additional reforms we should think about in the medical liability arena to make up for that. But that's one example of, and there are other examples of those special programs that Harold referenced that may have had a good purpose at the time, that are essentially at this point arguably throwing good money after bad to support and subsidize entities that are not going to sustain themselves. And there are opportunities to save money in those fields.
Laura?
I would like to echo Jim's comment earlier about the fear of trying to fix the world's problems in the course of 3 months, or 4 or 5 or whatever. And that, yes, there is a budget to balance, but this needs to be an exercise about finding solutions that make sense and not necessarily a shotgun approach to balancing the budget. And, of course, that all needs to be done. The legislature's going to want to get out of town a little bit earlier this year. But I share Jim's fear, and I think it could potentially lead to some dangerous outcomes.
So I would add the cautionary note about across-the-board cuts and things that are cutting in a somewhat crude way. I will say that given the order of magnitude that we're looking at, whether it's $3 billion or $1.5 billion if they lag payments again, and I'm talking about this year, we have it again repeating next year. You can't get there by cutting this, making this $20 million program improvement and $15 million over here. I mean, that doesn't get you where you need to be. And often the cost, not fiscal cost, but the impact is, in my view, not typically worth it. We spend enormous amounts of political time fighting often over what are very small things in the budget. So that really takes you back to some of these pool payments. Jim raised one. I've alluded to the fact that there are others. Even if you just started with those that are in the 9 figures, of which there are a number, you could quickly identify several of them, all of which have 9-figure types of savings to them that I think have outlived their real-world usefulness, maybe not their political usefulness, but certainly their real-world usefulness. And it gets you closer to solving the problem.
You want to name names at this point? I mean, are you talking about VBIP and VBAP and VAPAP?
I'm not, although there's a lot. That program, I would say, is not. There are, I think, stronger policy arguments there. So I will say one, which is the equity pool, which was a special pool that was set up to smooth out some issues around DSRIP funding. I think it largely supports hospitals that are probably financially healthier than others. There was a reason why it was done 4 years ago, but I think in this kind of crisis, I would say, do we still need it? I mean, it's not, I'm always careful about trying to gore one ox over another because this is a panel discussion, but I would still say that, and what?
There's nobody from the hospitals on
tried.
our panel.
Well, okay, but look, nobody, there's always issues when you pull money out midstream from anybody, okay? I mean, in fairness, people budget for it, they count on it to suddenly pull those dollars out. It may look easy on a panel, but in the real world, it's hard to manage when you're on the receiving end. But looked at even on a slightly longer horizon where you are not upsetting expectations quite as much, there's very little ongoing reason for that program.
So I guess there's another sort of topic in the news that I'd like to get the panel's reaction to, and I meant to bring it up during my discussion of what happened in fiscal 2019. At the same moment that the deficit was starting to accumulate in summer and fall, the health department awarded a rate increase. So the global cap told them they should be thinking about across-the-board cuts, and instead they did a rate increase for hospitals and nursing homes. It was 2% for hospitals and 1.5% for nursing homes. There's been different estimates of how much it costs, but it's definitely in the 9 figures. And that's the state share. I mean, it seems like I would have thought that would be the first thing to go. And in fact, in February, when there was brief talk about a crisis in the state budget, that was on the chopping block. Do you guys have any comments about like what happened there and why, and whether it should be rescinded?
I'll just say that I think that's a perfect example of loopholes or exceptions or whatever term we'd like to use, and the lack of transparency around how some of those things happen, that I'll leave it at that.
Anyone else?
I think I asked Jason Hogerson during his time as Medicaid director what was the most surprising thing he found about New York State. And he did talk about the influence of the hospital unions as being something which in New York is a unique phenomenon. It is not totally unique to New York, but I think it is probably more. It's a very powerful force, and it's not just the political activity, but it's a large constituency of people who are involved in politics in a direct way, and it has been a challenge, I think, for every governor to come up with policies, and for the legislature to come up with policies that are in the best interests of the healthcare system. And again, they deserve a seat at the table. They play a very constructive role, but that's part of the dynamic.
My next question, we've been talking about kind of the delta of health spending. You know, is it going up? Is it going down? Our base in New York State is one of a very high level of Medicaid spending. Can I borrow this for a second?
It's a great report.
Yeah, so on a per capita basis, per capita meaning across the whole population, not just people on Medicaid, our Medicaid spending is, in 2016, was $3,200 per resident of New York State. That is almost double the national average, and it's higher than the next highest state, which is Vermont. Like, compared to all states were high, compared to big states were really high, and that's 2016, so that doesn't even include some of the recent increases. Why is that? I mean, I've kind of looked at our demographic situation. We're older than average, but not that much older. We're poorer than average sometimes, but we're not that much poorer than average. We have concentrations of certain conditions, HIV and things like that, but we're not outliers in those areas. We are an outlier when it comes to Medicaid spending, even compared to other big expensive states like California and blue states. What is that? Why is that? Is it because of I mean, we often talk about how we're like a generous state. We believe in generous spending on social programs, or is it the political dynamic? Anybody?
Yeah, I mean, I think, as we sort of talked about, it's kind of a combination of those things. I think there's to some extent we have a very, we have personal care, we have a very expansive long-term care benefit, we have a lot of benefits that we covered. We also have a high price point, and I think, we've talked about minimum wage. I mean, whether you think it's a good thing or a bad thing, it's something that the state is funding, and that's a higher cost than other states.
And it's, Rose's, Medicaid is a verb as well. For decades, where there's a new program and there's an opportunity to seize federal financial participation, it drives policy, and it has driven policy even up to the present, as Health Home was a great example. We pay for things. There's often been comparisons between California and New York, and quite appropriately, it's New York apples versus California oranges. When you try to compare the two, we pay for a lot of things in the mental hygiene arena, for example, through Medicaid that is not paid for by Medicaid elsewhere. It means, for example, that we have a better system, I think particularly for people with developmental disabilities than they have in many other states, because we've been able to draw down that federal share. But it makes comparisons state by state difficult, but there is a price we are paying for the fact that there has never been a program that offers some federal financial participation that New York has declined to participate in.
So maybe at this point, we'll take some questions from the audience. I'm assuming people have those questions.
John.
And also,
John?
how would it be if we took like a 5-minute break before we do those questions? Would that?
Can we keep going?
Okay, we'll keep going.
John had a question.
People are in their seats.
And Mary Beth has a microphone. Where is Mary? Oh, there she is. So we have a question over here. We need to use the microphone.
Probably loud enough.
No, we need to use it because we're recording.
All right. I wasn't going to say this, Bill, but with respect to your last comparison, yes, New York's expensive. It's much more expensive than most other states, and a couple of points were just made. But I'm guessing that national average would look different if you excluded from the calculation those states that did not take advantage of the Medicaid expansion in the ACA. Those states made deliberate choices, frankly, to insert your own verb, their own constituents, while they were paying taxes that go into our healthcare system. So when we used that per capita, we didn't need to make that adjustment 20 years ago. We do need to make that now. The other thing I was going to say goes back to, I thought, Jim's very astute observation about the quality of the thermometer. And I would suggest the following. The thermometer in New York, in our cap, is adjusted in a manner that is totally consistent with the way we've done business for a very long time. It's provider-focused. It is a rolling average of the medical component of the consumer price index. It's provider-focused. There's nothing in there explicitly about clients. You are correct, Bill, that Medicaid enrollment stabilized several years ago. But when you look at the internals, the non-elderly Medicaid population has fallen by 300,000, and the elderly population enrolled in Medicaid has gone up by a roughly comparable number. And in looking at trend lines data, in my experience, I have rarely seen a line for 10 years worth of data that's as straight going up as the increase in the elderly population enrolled in New York. So if we're talking about tinkering with the Medicaid cap, what I would suggest we consider is an adjustment that's client-focused, and that is to age-adjust it.
You know, sort of relevant to that, relevant to something that was said earlier, when there were these Republican proposals to repeal and replace, and some of them included block granting Medicaid, and in particular, they included a per recipient cap on federal aid. And they often, first of all, they were per recipient, and second of all, some of them said the medical inflation rate plus 1 point. And so some of those proposals were significantly more generous than the global cap policy was when enrollment was going up. And I just thought, I wanted to support Jim in his getting out on a limb on that. Some of those formulas would have resulted in quite a lot of money flowing to New York State. Was there any other questions or comments? Here. Can you hang on for the microphone?
Well, obviously, thank you. This has all been very helpful and inspiring. I want to get back to, I've been in the provider business provider industry, not-for-profit, for almost 50 years. I know I look young, but anyway, you got to look at, I'm looking at the perspective of long-term planning and what Rose was saying. I'm looking at Rose, that first graph, that first bar chart of health, let's call it social service or community integration versus health. And a lot of the European countries have more of a focus on, we need housing, we need food. I call them poverty-based care services that get dumped into Medicaid, into the medical plan. And I even read an article by the head of Kaiser Permanente, which said that only 10% of our health care problems could be treated by a doctor. 90% are community-based, poverty, housing, et cetera. So I don't know what the long-term, I'm only making a comment that I think we have to look really at that paradigm of what's Medicaid and what's other things going on that are being dumped into the Medicaid pool, okay? But I've been working in the developmental disabilities and brain injury for this time, and just terrible planning went on over this period of time. And sometimes in taking Medicaid, it may be fool's gold, because we wind up with rules that don't meet our needs of the people that are more about community integration. So the one last thing I want to say about this is that when the state came to the idea under getting people out of institutions, because it was terrible, and the judge says you do it or you're not going to get money, and the Cuomo signed the consent decree, not Cuomo, Carey, they sold this thing that, oh, we're going to get all these people out of institutions, and we're going to save all this money. It's this immediate save of money is a problem we have. The long-term situation was that when they realized how expensive the development of disabilities community program would be, they came to agencies like us and said, why is this so expensive? And what we said was, you won the game. People are living 30 years longer. Okay, fine, it costs less. They're getting more integrated care now, but they're living 30 years longer. They're not dying at 50 from too much drugs or medical conditions. So I think we have to really, I don't know what your short-term solution is, other than we're all going to get pinged by the governor or whatever, but they have to look at what the Europeans have done. Is more of it is about community integration, socialization, poverty, and housing, and not so much as about calling this a medical condition and then measuring it with some rigid standards that really aren't that great.
You know, on that note, there's something I'd like to get the panel to weigh in on. There's talk about, what are they called? Social determinants of health. And there has been a couple of cases where, as part of the MRT process or part of Jason Helgerson's vision of things, where they took Medicaid money and spent it on housing. Or they took Medicaid money, there was some talk about spending it on pre-K. And they could point to evidence that, you know, if you have quality housing, decent housing, and your medical providers know where you are, they can improve your chronic conditions and your addictions and things like that. And likewise with children, if you get them into school and they're being seen by other adults outside their family and they're learning their vocabulary and things like that, that ends up paying a dividend in terms of their health care. But it seems to me there's kind of a slippery slope there in which you start redefining all aspects of life that have an impact on health as a form of health care, and you define it as Medicaid, and I'm just wondering, like, is that the way we should go? Should we be spending healthcare dollars on social services, or should we be finding a way to shift healthcare dollars out of healthcare and into social services? Anybody?
Yeah. I mean, I think that's the question that I would ask. I mean, I think one of the issues around home and community-based services being less expensive is if you have a home and if there is a strong community-based services support. You know, I mean, I think for better, for worse, a lot of people have traditionally, historically, I will say, been in institutions because they didn't have any other place to live. And I would say that, you know, so then when you want to say, okay, people can live in the community, they can, and perhaps their medical services are not what they need. Maybe they're in an institution because they need activities of, you know, they need assistance with their activities of daily living, which are not necessarily medical services. They need a roof over their head. They need to have they need to not be socially isolated, right? I mean, you can do that in a congregate setting. So that if people are moved out of the congregate setting, you need to recreate those. They're not medical services. If you're going to do that, then you need to be able to invest in that infrastructure. I think that there's, you know, that goes for, especially with an aging population, that's an important consideration.
So I would just add something to that, which is that it's difficult to accomplish the integration of spending on social determinants of health with healthcare without some structure sitting there being accountable again and being able to track outcomes to say, yes, we got housing, but we saw reductions over here, avoided hospitalizations or less medicine. Now, that may be these new value-based entities that are part of Disrupt 2. These are PPSs were sort of doing some of that, but not as well integrated with health plans as maybe they should have been. But you can't just do it. You can't just say, okay, we're now buying air conditioners and housing and this and that, and there isn't any accountability to accomplish those things and to see if you're getting the right trade-offs. Again, both from quality and from a cost perspective, without some entity sitting there and being responsible for both the costs and the outcomes.
No,
Otherwise, you're
I thought that was one of the virtues of the cap was it gave you some leeway to say, okay, I have an idea. We're going to spend money here and it's going to save money here. And so you could experiment in that way, but in the end, you had to save the money. So you couldn't get away with an experiment that didn't work. in
The
long run.
challenge is, and it's true of the entire budget process, I suppose, but the challenge is that you need to accrue those savings in a time frame that's not realistic. You're going to provide better early education for children. You're going to provide better food and nutrition services for a family. You're going to provide better prenatal and postnatal care for new moms. All of these things we know save money in the long run, but they don't save money in the next 12 months in many instances. And that's the challenge. And were it possible, I'm not sure how to do this, but were it possible to essentially recognize those savings, some of which are not going to occur within that next fiscal year or that even a 2-year Medicaid budget cycle, then we would be able to do that. But I think it's unrealistic to think that you're going to save that much money in the short run by these much more important structural changes that we're talking about.
I think the other thing to remember, and I absolutely agree with that, is that Medicaid is only one piece of the whole picture, and that as I started with, Medicaid is insurance coverage, and it's one kind of insurance coverage, and that this type of question, I think, needs to be considered across all of healthcare financing or all of health, human services, social services spending, where the money comes from and how it's spent, not just a Medicaid question.
And can I just add one thing? Harold noted that these value-driving entities, this is something that's proposed in Disrupt 2.0, and I'll say my concern, I won't say my criticism, but that the monies has through Disrupt 1 flowed primarily through hospitals, and to continue that, to have give money to hospitals to address social determinants of health. Again, we have a social services infrastructure. Is it perfect? No. But why do we just sort of ignore it and pretend like it's not there instead of improving the structure we have, or arguably dismantle the structure we have? Like, why do we keep the system we have where we're spending a lot of money on the social services side and say, we don't like it. We're just going to create something completely different over here. That just seems very inefficient to me.
Beverly?
Oh,
Oh, and TK.
we'll come to this one.
Oh, I'm sorry.
Sorry.
Go ahead.
So just put quite a few different thoughts together, but to get back to the migraine that we're all here for. One is, if you look at America's health ranking, New York State, from a public health perspective over the last 30 years, has had the highest increase in better outcomes. So I think we are doing many things right. So that's important, baby bathwater. But I think it is interesting, we're talking about the waivers coming up, districts coming up. I think what we've seen out of the state doesn't in any way acknowledge this migraine, doesn't really look at this budget deficit that we have. And so my question, this is pretty wonky, but I think when we look at other states, a lot more is in waivers and a lot less is in statute. So states have a lot more flexibility than New York does. And so how realistic is it that we can make any other changes than a 2% across the board cut just because of the way we have put so much into statute versus, which really means the legislature on a political year of re-elections has to make some, be a partner in this.
Does anybody want to?
Yes.
Great.
I'm not sure this is relevant necessarily, but getting back to the discussion before about how you handle social determinants of health, if you treat it as healthcare, it becomes part of the healthcare budget. And the healthcare budget is first in line. Well, healthcare and education are first in line for the state's resources. But then within the healthcare budget, who's first in line for that? I would say historically, It has not been primary care. It's been institutions. It's been especially hospitals, nursing homes. And so I just wonder if there's a way to break that cycle, to say, yes, we're going to make an investment in healthcare, but this time it's going to be investment that doesn't go to the usual suspects. Is there like, how do you do that? Okay, that one's a stumper.
Well, getting back to her comment, I do think, the cap did provide a level of flexibility to the state. These superpowers is by it, the whole notion is to be flexible and allow the executive to make determinations. And now that the state senator and state assembly member who were here earlier are not here, I can say that the fact is, at least for the last several years, I don't think the legislature has played much of a role at all in any of this. I mean, the MRT process itself essentially excluded the legislature. If it weren't for Laura and Dick Godfrey, there would have been nobody to vote no to the MRT.
I abstained.
Yeah. Oh, I'm sorry. But so I think, I don't think New York is that constrained, frankly, by the limits in the program, has had a fair amount of flexibility and continues to, and it's been, I think, very much driven by the executive, and the legislature has not played a particularly significant role.
We had a question over here. Mary Beth?
My name is TK Small. I work for Concepts of Independence, which was the founder of the overall Consumer Directed Program almost 40 years ago. So it's good to hear that Consumer Direction is finally getting some discussion, because I think it's an incredibly important program which allows me to do things like go to law school, to work full-time, to attend an important meeting like this. I also sit on the board of directors of a now defunct MLTC. So I've seen this issue up close, both from a professional and personal perspective. I'm in a managed care company myself. I can't see that it really benefits me personally all that much. I mean, there's not a lot of coordination of my care that any company does. I do all my own care coordination with everything. So just for me personally, it's not really saving any money at all. But when the MRT was being considered back in the early part of 2012, I was in the legislature, sitting in the assembly, and there was sort of a rowdy protest going on. And then Assemblyman Hakeem Jeffries came over to me and he said, "Hey, what's going on here? What are you guys protesting?" Because they were chanting and cheering. And we were talking about this new creation of powers that would go into the Medicaid budget. I said to Assemblyman Hakeem Jeffries, I said, "You guys are giving away all of your power. And once you give away power, you never get it back." I think it's really an example of broken politics, broken policy, when there's not transparency to have a more robust and rigorous conversation about what's going where, how the money is being spent. These numbers are huge. And, what's going on, it keeps me awake at night, both, how's my care going to be covered, but also my company that I work for. I'm in senior management. We have a staff of 100 people or more that, serve 4,000 people in New York City and across New York State. So just giving away all of your power to the government, and we complain about, smoky backroom politic deals. This is the essence of a unclear process that nobody understands. And so I really think the key is transparency, to have more people understand what's going on, because the program consumer direction, which I think is unfairly being blamed for the hole in the budget, right? It was originally designed to help people with significant physical disabilities, and then I see, advertisements on subways and on cable TV. I don't know that those people. I mean, I want to help people, and if they need help, that's fine. But when we lump everybody together, not all Medicaid recipients are really the same. I just think that there needs to be maybe different programs created for different populations that can serve in different manners. But I just wish that the legislature would try to take back their power. But I don't know that that will ever happen. Thank you.
So any other questions, comments? There's somebody, oh, can we take one more question? I think we have one more.
Yes.
Thank you. This is a bit more of a comment than a question. This is also related to consumer-directed personal assistance. I'd like to point out that 9 out of 10 caregivers in the paid workforce are women. And I believe it was Jim who had mentioned that families who are enrolling their loved ones in this program, they had previously relied on unpaid supports. And I'd like to point out that that need remains, whether they're being paid or not. And overall, I think women are unfairly burdened with caregiving, and not because they don't want to do it, but they're often still in the workforce regardless of whether they're getting paid to care for their loved ones. So it becomes a second job. And they're also often caring for their own families. So I guess I'd like to know what the alternative would be to that.
I don't think there is one. The reality is exactly as you say it. It is an extraordinary burden. Everyone has experienced it, I suspect, in this room, of trying to figure out how to meet those extraordinary needs that a family member may have. There's no question it has fallen disproportionately on women over the years. The entire long-term care system seems to depend mostly on women to provide that service. We have some very large fundamental issues about how to address those needs going forward. The consumer-directed program, as I said at the outset, is a wonderful program that was designed precisely to provide the autonomy and independence that has just been discussed. It also is an important way by which people can get access to the services they need. It has been, I think, in a few instances abused, and it's important that we take steps to try to save the program from it being essentially besmirched by some bad actors. So I think your point is exactly right.
I'd like to wrap the program up by being a rude host and putting the panel on the spot and ask you to engage in rank speculation and maybe make a prediction. Bring you back to the beginning of the whole focus that of what we've been talking about. $1.7 billion is a really big problem in the context of the New York State budget, all money being marginal. It's the biggest Medicaid problem in isolation that I can recall over almost 40 years in terms of both its percentage and its total sum. The last time the governor had to close a gap in Medicaid in particular, he created the Medicaid redesign team. Lara referred to that. I believe you said you were on it. Something has to be done. As they say, if something is unsustainable, it cannot continue. Will the governor, what do you think will or should happen? Will the governor exercise those powers Harold referred to, that is, outgrow his clothing, turn green, and turn into, exercise his incredible Hulk-like superpower to slash rates and make that problem go away? Or will he convene another Medicaid redesign team, in which case, if you're not at the table, you're on the menu? Or will it be a combination of both? Because we spent a lot of time talking about what our aspirations would be if only it was a better world in which this whole program was run in a more rational way. Now, practically speaking, I'm daring you to sort of make a prediction and to speculate on what is about to happen over the next 6 to 8 months, because something must happen. It may be a $1.7 billion can may be kicked into next year, but it can't be kicked much further. So I would, in whatever order you would play, Harold, you've got the 9-figure solutions ready at hand, so perhaps you'd like to begin answering this question.
It may get kicked down the road. I think in other years I would have said more likely it will be kicked down the road, but I think there's a desire to start grappling with it now, just because, again, it compounds. It's hard to get to meaningful cuts without legislative changes if the legislature doesn't come back, unless you are invoking superpowers of some kind. But I would say, I wouldn't put it likely yet, but I would put it as compared to other years when the problem might have been smaller or the other tools might have been better, that certainly the indications are that there is serious consideration to doing something this year.
Meaning a combination of both techniques, or one or the other?
I think the MRT, obviously there was an announcement that they were going to create a new MRT, but it seems as though now it's just sort of gathering good ideas from lots of key stakeholders, which is analogous to the MRT in other ways, and gathering those up and taking them back and figuring out what can work and what can't work and what will get you. Again, the big issue everyone has said, that even major changes do not yield savings right out of the box.
Right.
So there's always a time lag, which makes it difficult if you are focused very short term on closing $1 billion plus or bigger gap.
Lara?
I think in respect, just sort of going right from that last point, we could potentially see some kind of combination, because that may be the only viable way, which is to say, sustain some across-the-board cuts and look at an MRT-type exercise where we look at other options. Going back to, again, the point that there's a problem to fix now, immediately, but also there needs to be a way to figure out some, additional options, some sustainable options, and some potential program changes. And I think that would have to be, looked at through an MRT.
So I quarrel, I think, with the notion that this is the worst it's ever been, because my memory is not good enough to recall precisely how bad it's been in other years. I feel like every fall I have the same conversation with clients about, there's going to be a really bad budget year. But anyway, so I
Stipulated it's not the worst adjusting for inflation.
Yeah, maybe that's true.
It's a real.
I would anticipate there's a very strong likelihood of both a renewed MRT-like effort and across-the-board cuts. One detail on that, I just point out, admittedly, from the plan perspective, the plans have, under federal and state law, a somewhat of a protection against those across-the-board cuts. At the end of the day, their rates are supposed to be actuarially sound. That's why the managed care plan that was referenced earlier is no longer with us. Those rates were not actuarially sound, and they did not have sufficient premium to pay for the cost that they were incurring. And there is a threshold that has to be satisfied there. It may be difficult, therefore, and since the bulk of the money is going to managed care organizations at this point, it is difficult to do across-the-board cuts if they're already on the low end of the actuarial range.
Yeah. I think there's going to be a hesitancy to invoke the superpowers in this current year. But I think that does give them I think that there will probably be some combination of pushing some of the problems forward. I think that doesn't mean that they don't have a problem this year, and I'm not sure how they're going to solve it, but I think they'll be hesitant to kind of take the heat. I think that a lot of that will be pushed into the budget discussions going next year. And then, the good news about, the thing about for the executive, the global cap gave them a lot of flexibility. It also gave them all of the accountability. So I think as they go into a negotiation for next year, they can engage the legislature. I think that's going to be a challenge, as Beverly pointed out. But then they don't have to, there's some shared accountability for the pain.
Are there questions, comments? We've tapped you all out. We've come pretty much to the end of our program, so unless there's any last words from, okay.
Thank
I
you.
want a really nice round of applause for this panel. Thank you all for coming.